Okay, I'd like to welcome our second speaker right here. Our speaker is Dr. Kendall Ho. Dr. Kendall Ho is an emergency medicine specialist in Vancouver and professor in the UBC Faculty of Medicine, where he leads the Digital Emergency Medicine Unit. His research focuses on using digital health and AI to support patients transitioning between community and hospital care. He also serves as the medical director for the BC Ministry of Health 811 Virtual Physician Services. His presentation is titled TEC4Home, Digital Health to Optimize Patient Convalescence at Home Post-Hospitalization. Please give a warm welcome to Dr. Kendall Ho.
Great. Thank you very much, Rishi. Thank you very much, everyone, and wonderful speaking. Really enjoy your presentations, Bruce and Katie. I'm not going to use slides, and I'd like to roam around a little bit, and I'm very glad we got the lights turned on. I want to make sure I don't put you to sleep. So as Rishi talked about, I'm very interested in technology. Maybe I'll introduce a little bit about myself. I'm an emergency doctor. I work in Vancouver as settler. In Vancouver, the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I'm a professor at UBC Faculty of Medicine. I lead a unit called Digital Emergency Medicine. Very interested in how technologies such as virtual care, sensors, data, wearables, and AI support patients in their care. I think I'm going to come back to these two very key points. That in my research, I benefit greatly from patient partners, because using technology is not just a one-way street. In fact, it's a very, very important two-way street. And so very important for me to understand that. And secondly, I'm very glad I'm in British Columbia with Michael Smith Health Research BC and SPOR unit supporting patient engagement, that in my grants and my research, I had the pleasure of being able to leverage that grant to partner with patients so that we can do our research. And so what I'd like to do is tell you a few stories. And one of the stories, they all center around bridges. I love bridge. I remember growing up, I have camera. My dad taught me how to take photographs. So in every town, every city, I'll go and take a photo of the bridge. It always gives me the sense that you have two places that historically are separated, but the bridge brings you together. If the bridge is well constructed, people feel very, very good to walk on the bridge. If it's not, then people will be hesitant and say, yeah, you look like you have a bridge, but you may not. TEC4Home really is about a digital bridge to support patients between hospitals and home. Now, in many cases in our health system, we support patients when they get discharged home. We want to make sure that they go home safely. And by and large, many times we do that well. But I would submit to you, many times we don't do that well. When the patients want to go home, or when a patient needs to go home, that they're not well supported. And so en route home, that we may think that it's a beautiful bridge, but to them it's more like a drawbridge, maybe missing a few planks, and they may fall between the cracks. So what I'd like to do is to identify how technology can support a better bridge. And so for TEC4Home, really it's about, when I first started this study, it was around 2015. At that point, the wearables is just coming out. Having home blood pressure, having home, you have a weight scale, you have a thermometer. But to have blood pressure cuffs, not everybody has it. To have an oxygen saturation probe, very, very unlikely. And so in those cases, we start looking at, well, how can we leverage these type of technology to build a better bridge? In emergency, I do see patients, especially patients with chronic diseases, who tend to come into emergency and become friends to emergency department. Not that they want to, but it becomes a revolving door. Heart failure is one of them. Very challenging for patients with heart failure. One, their heart is not pumping as well. So it's very delicate balance that we give medication to strengthen the heart. We give medication to draw out the extra fluid in the body. And also we ask the patient, you may want to restrict your fluids. And at home, they may have a scale to help them to make sure they don't gain too much weight. That's about it, right? However, your blood pressure, your heart rate, your oxygen saturation, we know that we change during the day, that those fluctuate. If your blood pressure is a bit higher, you need some more help with your heart to make sure your blood gets to the right places. And so for patients at home, very, very difficult for them to titrate that. And then secondly, they do it alone at home. And we as health professionals, maybe I'll give some advice, but if they go back to their home, that advice becomes discontinued. And then the third is then obviously the challenge of balancing all those numbers. As a physician, I may have some advantage of knowing, blood pressure, heart rate balance, but for the patient, very, very challenging. And so for heart failure, no question that it was a challenging condition. In fact, 1 in 4 patients at that time, 2015, ended up coming into hospital again 1 month after discharge, 1 in 4. Imagine your car, your transportation, that your car, every 4 times you start the car, 1 time it doesn't work. You have to take it back to the shop. That's how heart failure patients feel, and many chronic disease patients feel. And so I was excited to be able to bring that research forward. In 2015, we got a 4-year grant in CIHR to absolutely look at that area. And so we did a feasibility study in Vancouver General Hospital, and St. Paul's Hospital, and Kelowna General Hospital. And with the feasibility study, we found that if we discharge patients home, support them to give them a blood pressure cuff, oxygen saturation machine, a weights scale, and more importantly, to give them the ability to upload that data onto the internet so that we at hospital can actually look at that data. And then we have a telephone to be able to talk with them, to support them. And then finally, a 1-sheet paper to say, well, what are some of the ways that you can adjust? Those show that, in fact, there's a 60% plus reduction of emergency department visits. There's a decreased hospitalization, and the patient feels 100% better. That's based on EQ-5D scale. And so in those cases, but the 2 things that really stick with me was, one patient said, I've never felt better in my life the last 3 years. And then the second was from a pair of sisters, said, my father never looked that good. And in that CIHR journey, I had a chance to start working with patient partners. And then Michael Smith had the health professional investigator program. So I was able to apply, I was able to get some longitudinal funding. So Bruce, I absolutely feel your pain, and Katie, grant to grant, it's very, very tough. But that gave me a bridge again, funding bridge, if you will, so that I can carry out these type of research and engage a patient partnership committee. And in fact, Linda is one of our patient partner. So wonderful to see you again. And so in those cases, that's a second bridge, that the patients is invaluable to our study. What the patients helped me, what Linda specifically helped me, and also our community helped me, is to, number one, understand the pain of that journey, patient with lived experience, the pain points that they have. Initially, I still remember that first committee. I don't know, Linda, whether you remember. I was saying, let's think about some of the pain points. And I came to the meeting, said I identified 11 pain points. By the time I walk out of that meeting, the patient partnership gave me 42 pain points along the journey, right? So things that I didn't even think about. Of course, we're all patients, but I'm not a patient of heart failure. I don't have the lived experience for it. Right? So sense making for the pain points. Secondly, when I designed my study, I remember another patient partner, I was saying, this is what we plan to do, send patients home with monitoring so that we can monitor them and we can remotely also communicate with them. And the patient said, fantastic idea. And then she adds something. She said, would you like to call it co-monitoring? So in fact, it's not just you monitoring me. In fact, it's me monitoring myself, and in fact, it's about partnership on that. That was amazing. I would have thought of co-monitoring, right, 2015. It was amazing that that came up and allowed me to do that. And third, data analysis, right? As we collect the data, as we design the study with our patients, as we collect the data, the patients group gave us so much deeper interpretation of the data itself. And then finally, we co-write papers together on the authorship on that. And so with that, in fact, a bit unfortunate that when we went from that to a randomized controlled trial with 21 communities in Fraser Health, Vancouver Coastal Health, Interior Health, that we're able to get to our year 2, and then COVID hit us. And so for about 2 years, we got delayed a little bit. However, I love lemonade, making out from lemon. What COVID did was it actually turned the use of technology significantly higher. And so at that point, we start talking with Fraser Health, talking with Vancouver Coastal Health, and they start adopting it in part of their home practice. And so to this day, some of those protocols that are still being used in those communities. So it really helped us to improve on the impact side. And also, we start extending that to blood pressure management in hypertension. I'll tell you a story about patients with hypertension. It's challenging for us if a patient comes into an emergency department with blood pressure that's elevated. We'll be wondering, do they really have high blood pressure? And if they do, we'll need to treat them with medication, right? On the other hand, is it because they're not used to emergency, they're anxious, they don't like seeing people in white coats like nurses and physicians? We don't do white coats anymore, actually. They don't like seeing patients. Scrubs, maybe. Maybe that's what caused the blood pressure to go up. And so sometimes it's very hard for us to decide, do we treat? In which case, it may be a mistake of commission. If they actually have normal blood pressure when they walk out, I give them medication, they take it, they'll faint and come back to the emergency department, right? How about the error of omission? If we assume that this is a white coat syndrome, and we say, let's not treat, see a doctor in 1 or 2 weeks, during those 1 or 2 weeks, there's no monitoring, and so the patient may be at higher risk for stroke. And so with a partner, Dr. Karen Tran, who's a hypertension expert in Vancouver General, we got together and with support of Michael Smith, the health professional investor grant, we would then extend that to apply for a VCHRI grant to actually do a pilot study with 50 patients and actually demonstrate that by sending patients home with blood pressure cuff, 63% of those patients actually have high blood pressure that needs to be treated. And also the fact that if we monitor them daily, then in fact, we can then use that as a time to come back to see a clinic faster, as opposed to wait in 2 weeks, 1 week to see a family doctor. And sometimes it's hard to make an appointment with family doctors. And so with this type of approach, again, having patients together, understand that journey, move forward together is very important. And so I'm going to introduce a third bridge. It's the bridge from today till tomorrow. Monitoring wearables. How many of you have wearables? Wear something to monitor yourself. Yeah. So we're seeing a lot. Okay. So in fact, more and more, for example, some of you may have heard about Hospital at Home, which is a hospital program, a health authority program, where instead of, when I went through medical school many years ago, I'm not going to tell you how many years, if you have lung infection, you're automatic admission to a hospital. And then we'll give you antibiotic through the vein, and you'll sit in the hospital for at least 3 or 4 days. Once you feel better, we switch you back on the oral antibiotics. During those days, you may need to be in hospital, but many of us may not be that sick. And so you'll be wearing a hospital gown, walking around the hospital, feeling comfortable sleeping. But if we select the patients well, since 2018, Victoria is the first hospital at home program, 2018. And now we have 9 hospital at home programs across the province. And we find patient partners to understand how can we leverage this program well. So for those patients who don't need to stay in hospital, they can go home and we can send nurses and treat them in home and use remote patient monitoring, sensing to monitor them at home. Now, there are limitations, of course. Again, Linda gave me a wonderful insight that, sometimes it's very hard if you live in a very rural location. Hospital home is one of those that you still need to stay fairly close to the hospital so that the home nurse can come to you. Heart failure, you still have to stay fairly close. We still have to look at those geographic divide, those digital divide if you don't have technology. So on technology front, how do you do that? And finally, I'm going to bring to the bridge to tomorrow. As we continue to have better and better wearables, what it does is not only support patients for self-management, not only does it support the partnership between patients and health professionals, but it takes us to tomorrow, AI. It takes us to the fact that today, if you use AI, ChatGPT, large language model, you can tell them stories. You can tell them about your past medical history. You can tell them about what you feel today. but it can't detect your physiology. It doesn't know you minute by minute, hour by hour. But with technology, with sensors and wearables, we start to be able to do that. So how do we leverage that ability to actually follow patients in this period and then actually get more accurate? Now, AI has many challenges, but also has many possibilities. That's where research becomes important. It's not just a concept, but how do we generate evidence? And finally, with AI, digital health, we need patience, because those journeys we create with you. I can't imagine myself. I can't think of all the pain points. I won't be able to understand all of the lived experience. And that's why partnership becomes very important. And that's why SPOR is important. And my final point is this, that technology is very good, AI is very good. But coming back to what Bruce and Katie said, we cannot allow technology to get in the way of relationship building, because that's the secret sauce. Using technology, if it separates us from our patients, that's not a good use. But if it actually builds our relationship so that that partnership becomes stronger, that's when the health system benefits, that's when our patients benefit, that's when our research benefits, that's when clinician benefits. So I hope that I give you a sense about why this is such an important topic that's close to my heart about patient engagement, because there's so much we can tweak of using technology, and that partnership is so important. And funding like Michael Smith Health Research BC, allowing us to partner with patient is so important. And then finally, thank you for being here. Love to work with you and all of you to understand the journey of how technology can build that bridge between hospital and home. Thank you very much.
Thank you so much, Kendall. That was fantastic. I loved your analogy with bridges. That was wonderful. I'll make sure next time I cross a bridge, I will think about that. I will send it to you. We have a lot of questions here. We'll start on this side.
Excellent. Your presentation is exactly where we're going at Ideal Lab. And the question is about the left behinds. These are the people. I do not carry a cell phone. I do not have a credit card. I do not know, because I have dementia, I cannot use these functions. So how do we complement the idea of robotic devices so that it is a no touch, no activity activation from the patient, but would be sort of helpful, exactly what you're looking for, kind of thing. Yeah. Thank you.
Thank you very much. Maybe I'll point out 3 things for consideration, and I welcome your reflection too. Number 1 is, yeah, digital divide is real. You know, in rural remote, you just can't access it. People who have challenges using technology, it could be difficult. What we need to do, what I need to do, first to listen to them. What's the barrier? How do they use it? And so currently we have a research cluster called AI and Technology Enabled Care Collaboration Center, ATEC. So we actually go out and reach out for underserved groups to say, you know, how can AI help you? I'm always constantly surprised by the resilience of people who says, yeah, I have this disability. I can't, you know, I have eyesight problems. I have hearing problems. So for me, I say, well, it's tough to read computer screen. They say, no. In fact, there are many, many different tools I can use to get me there. So those are the things that help me. Just like that heart failure, I may anticipate 11 pain points, but there may be 42 pain points. But I may anticipate 1 or 2 solutions, but there may be a lot more solutions than I'm aware. Secondly, we got to keep trying. We got to keep doing it. And in fact, research is not only to try, but to try with evidence, so that we can then make the case to say this is not only important for one person, but make the case for population, and then advocate for funding research to put it into practice, like you know, engaging the health authorities to take up remote. And then third is advocacy. There are structural changes, like, you know, we just don't have connectivity in the north, in the rural locations. How can we leverage the importance of evidence, patients, to say, how do we increase equity of access to care and leverage that together to get access? So hopefully those 3 ways are some of the ways that I think we can try to overcome it, one day at a time. Thank you.
I just wanted to say thank you for pointing those out. I am an Indigenous person who lives in the north, who worked for Northern Health at one point in time, and I have children who have neurodevelopmental support needs. And I was on a research project with UVic called Tapping into Tech, and it looked at examining where is the use of technology for supporting families who have kids like speech and language, occupational therapy, physiotherapy, behavior intervention. And one of the things that, the 2 points that I wanted to make and kind of ask the question around was one of the questions that was asked was, when is it inappropriate to use technology? And we developed insights around that community of practice around supporting families with kids with developmental disabilities, which is a little bit different than what you're talking about. So that's one question, is if there is any time where there's been feedback where it's like, hey, this is not the right use. And then the other, you kind of touched on it a little bit about those questions about accessibility, affordability, and you know, that was one of the questions that came up for us as well, was what if they can't afford, you know, internet use? They can't afford a device, they can't afford that. And we looked at what some of those solutions about community access to technology. So it was something being housed within, say, like a health center on reserve, or within like a band office or something like that. So the other, that was one question. The other question is the environmental impacts of AI use. I always bring that forward because I understand, you know, right away we're like, hey, this, you know, this technology, this is going to be able to help because, you know, telehealth, that makes sense. But when we're looking at the environmental impacts of, you know, of AI use, where do you draw the line about what's beneficial, you know, and justifiable versus the environmental impacts, given that a lot of groups, especially Indigenous groups, are the ones that end up getting that environmental impact with data centers and things like that, and that the caution around the actual like drinkable water and things like that. So I hope that makes sense.
Absolutely. So one, how can we use it safely? Two, affordability. Three, environmental impact. So on the safety front, by the way, I'd love to talk to you later. I'm sure you have insights for me on all three. For safety, what we usually ask is 4 things. One is, when you use AI technology, make sure you don't use it yourself. Number 2 is always have a trusted health professional partner with you to do that. And that's something we need to learn too, because sometimes as health professional, we tend to write off, nah, you know, don't check Google. You know, what's this about ChatGPT? Listen to me, right? We need to learn. But having a trusted partner is very important. Number 3 is disclosure. And then 4 is we learn together. I think those are important 4 points, because there are, it may not surprise you, 10 to 20% of youth, in a study that was 2 years ago, it may have accelerated, 10 to 20% of youth use large language model as a confidant. That means they don't tell anybody else. They tell ChatGPT about themselves. And so that's where the risk of suicide, the risk of all those becomes important. So disclosure, don't use it alone, have a health professional partnership, and we learn together. Those are important. Affordability, absolutely. I think it's one of the things about research. I'm going to keep it very short, Rishi. I apologize. I'm a long-winded guy.
You got time, don't worry. We're here to see you speak.
In hospital-based or health professional-based technologies, we have to use, most of the time, medical grade. It's hard for us to rely on a consumer-grade device. Now, if you say, you know, I have 10,000 steps, you miss 500, won't kill you. But if you said my blood pressure is 120, but your real blood pressure is 100, it may make the difference whether you faint or not, right? And so we need to make sure it's medical grade, and we need to make sure if we use that for hospital at home, for example, we will provide those type of technology, but then we need to then start looking at what's the cost effectiveness, what's the value for money. And so in those cases, evidence becomes so important to demonstrate that, as opposed to, you know, oh, here's the technology and go home, right? So there's only so much we can afford. And so evidence, again, the research becomes very important. And then finally, for green effects, absolutely. ChatGPT AI use a lot of power. The balance is, what about saving patients' trips? What about decreasing, CO2 emissions? With my role at 811, thanks to Ross, we're working together on those. We found that over 5 years, we saved patients about $34 million. And also it reduced CO2 emissions. So we need to look at that type of balance too, and then make a good case to say, well, how do we build the balance and go from there? Hope that helps. Thank you.
Do you have a question right here? Sure. We can go with Kent.
Yeah, thanks again, Kendall, for another great talk. And we've heard you talk a lot about how AI can be used to help ensure that every patient has a discharge plan and makes use of home IV, home and community care, nursing, telemetry, etc. I wonder if in this exploration of AI, have you considered the potential of implementations of AI at the other end of the clinical encounter, meaning during the triage process? Because many of us, especially with chronic conditions and disabilities, have experienced what I'll generously call gaps in care because our complicating precedents are not well understood. And the more that the clinicians and patients are able to communicate and understand all of the factors that should go into a diagnostic and treatment decision, the better the treatment outcomes are likely to be, and the less apt we are to have people dying in the waiting area of the emergency room. So it seems to me that there should also be potential use of AI in triage as well.
Thank you, Kent. I'm very glad to point out that Kent was part of our patient partner group, really informing on doing an app for sharing information. So thank you very much, Kent, for your work there. So yeah, absolutely. So AI has the potential of giving good information for triaging patients. I think earlier last session, there was a discussion about how AI could be used. I think Fagan makes some really good point, decision support, diagnosis, very, very good. I think triage, stratification of patients, who needs to be in emergency, who doesn't. We're working on it in 811 right now. And also, as the patient improves, how do we use AI to smooth that journey, right? The good thing for us is when we look at AI, say, wow, this is amazing. I can see 9 out of 10 things are very, very good, this AI. That one thing, yeah, you need to, it was just doing a little bit of hallucination. For the patient, though, it's very hard to tell what that one thing is, right? That's the challenge, right? And so there always need to be, in any AI application for today, that there needs to be a human in the loop. So we use a chatbot in any function that you do. Make sure that there's, again, a health professional that can leverage that knowledge. And also, we use it as a health system. We need a health system in the loop. The health authority needs to be there, looking at how that's being used. I think for today, that would be the best strategy for that combination. Tomorrow, in a decade, I don't know. Maybe AI will be better. Having said that, there'll always be the relationship building piece that's very important.
We'll just do one last question right here.
Thank you. So it's 2 parts. One is a hurrah for Kendall. So if any patient partners are in the room, you could not ask for a better research lead than to work with Kendall. I can attest to that. So he set the standard for me. Nobody has matched him in terms of being a research leader since I first worked with him. So I work with him if you get an opportunity, because total respect for patient partners. And yeah, so that's the first part. The second part is, I live north of Prince George. So 10 years ago, when I had a heart failure diagnosis, at that point, over 500 patients a year were flown south for heart work of some kind. Can you imagine the cost and the pollution and all that? Those people get flown home again, not to cardiac care. They don't go home to see cardiologists. Most of them go home to nothing. And so I'm encouraging researchers to look at doing research beyond the South. I know a lot of research is done in major population centers across the country. Like, I went to an event a year ago, and sitting at the table with me were 6 cardiologists from London, Ontario. And I was like, where do you guys come from? Like, and we were in Vancouver, and there were 6 cardiologists from London, Ontario. And they said, oh, well, we're the heart of cardiology in Ontario. And I was like, well, come to Prince George, you know, like, but we've been told that Prince George will never have a cardiac center. And when I first went home, there was a cardiologist who had been promised a cardiology center, and he left a year later because that was withdrawn, because the government has said we will never build a cardiology center outside of what is now existing. So it's not about research to prove, well, we need a cardiology center in Prince George. It's like, what other solutions, such as what our first presenters were talking about today, which is coming up with solutions. It's, you have this vast area of the country of patients that, are they gonna keep getting flown to areas and go home to areas where there are no solutions? Like, that's not healthcare. So what can we come up with? And maybe it's technology, as Kendall says, you know, to monitor them, to keep them from going back to EDs. I don't really know what the solution is, but there's got to be something besides flying people back and forth to ED departments. And perhaps that's what we need to look at down the road. So thank you. I know it's long-winded.
Thank you. Half a minute?
Nope.
Great, thanks. Linda, absolutely. We need to do more studies throughout the province, not urban-centric. Completely get your point. Welcome that lot. A quick story, and then I'll answer, and then we'll wrap up. When I was young, growing up, when I think about shopping, I think about driving to downtown. Today, I say the word shopping, my kids bring out their mobile phone and say, hey, here's Temu, right? Today, if we have a health urgency, we think, do I need to drive to emergency, right? When would it be that one day we can take the service to the patient's home so they don't have to necessarily come if they don't need to, right? That's where, Linda, I'd love to see the bridge to tomorrow, to say that at your home, you are well equipped so that there's a bed in your home that may be able to turn into an acute care bed, like hospital at home. Secondly, to have the type of monitoring and communication so that we can reach you. You don't have to come to us. And third, to have AI that's actually well-trained and well-tuned to you to understand your electronic health record, understand your medications, understand your conditions, and why you have this condition today. And we as humans keep that loop together. Boy, if we have those 3 ingredients, we're starting to look at Temu of tomorrow of healthcare. I hope that will get there.
Perfect. Well, thank you, everyone. We can give Kendall a round of applause. Thank you, Chad. Appreciate it. I won't keep you long. We're a little over 12:30. Please feel free to network, have some delicious lunch. If you need to connect with anyone, I'm sure our speakers would be happy to connect. If we can also give a round of applause to our AV team for being incredible. Thank you. Thank you. Have a great day, everyone. Take care.